Hello, everyone. I would like to thank the conference organizers for this opportunity to present. I'm going to talk about a study on access to hepatitis C prevention and treatment among people who inject drugs in Montreal. And so I have no conflict of interest to disclose. So the hepatitis C virus, or HCV, is a blood-borne virus. And in developed countries, it's mostly transmitted via unsterile needles and drug paraphernalia. In Canada, it's estimated that around 250,000 people are chronically infected with HCV, including 21,000 people who are co-infected with HIV. And co-infection with HIV exacerbates the gravity of hepatitis C infection by reducing spontaneous clearance rates and by accelerating liver disease progression. There is currently no vaccine for HCV. And before 2014, HCV was treated with interferon-based treatments, and those caused many adverse reactions and had low cure rates. However, in 2014, second-generation direct-acting antivirals were introduced, and those really revolutionized HCV care as they are well tolerated and have cure rates above 90%. So the introduction of these treatments encouraged the WHO to adopt global targets to eliminate hepatitis C as a public health threat by 2030. Canada is not currently on track for HCV elimination, and one strategy to incrementally achieve elimination at the national level, is the micro-elimination among priority populations that are at high risk of acquiring and or transmitting HCV. And people who inject drugs have been identified as a priority population. In Montreal, 60% of HIV negative and 85% of HIV positive people who inject drugs have been exposed to HCV. And we know that HIV positive people are more vulnerable to HCV infection, but HIV positive people who inject drugs are also more likely to be already engaged in care, so that makes them a good candidate population for microelimination. And we know that access to HCV treatment will be key, but we also know that harm reduction programs are absolutely crucial in order to prevent transmission of hepatitis C among people who inject drugs. And these programs include needle and syringe exchange programs, which started in 1989 in Montreal, opioid agonist therapy, which was started in 1999, and supervised injection sites, which were recently introduced in 2017. And so if we want to eliminate HCV in priority populations, we really need to quantify the gaps in access to prevention and treatment. And we have very little information on the coverage of these programs among HIV positive people who inject drugs. So our objective was to estimate temporal trends in hepatitis C treatment initiation and effectiveness, injection practices, and access to harm reduction among HIV, HCV co-infected people who inject drugs living in Montreal from 2003 to 2018. And so to do that, we used data from the Canadian co-infection cohort. It's a study of more than 2,000 HIV, HCV co-infected patients. Visits are scheduled every 6 months, and data are collected through questionnaires and chart reviews. And blood tests are also performed at each visit. And so we estimated a number of outcomes. And this is a flowchart to represent the denominators of these outcomes in the boxes, and the outcomes themselves are described in blue. So I'm going to take you through it. The first thing that we did was to restrict our study participants to a sample of people who were recruited in Montreal and injected at least once between 2003 and 2018. And this is where we estimated our table 1. Then we defined 3 time periods of interest based on HCV treatment guidelines in Canada, 2003 to 2010 for interferon-based treatments, 2011 to 2013 for first-generation DAAs, and 2014 to 2018 for second-generation DAAs. And we used the same process for all time periods, so I'm only going to describe it for the first one. We estimated HCV treatment rate among HCV RNA positive people, and we estimated HCV treatment effectiveness among those who received treatment. Then we restricted our sample for this time period to the visits at which injection drug use was reported in the past 6 months. And there we could estimate the proportion of visits at which there was any needle and syringe sharing, opioid consumption, use of needle and syringe programs, and use of supervised injection sites, all of these in the past 6 months. And then we further restricted the sample of visits to those where opioid injection was reported, and because then we could estimate opioid agonist therapy engagement in the past 6 months. So just some details about the HCV treatment initiation rate. This was defined as the prescription of any regimen, and people who were susceptible to receive treatment were HCV RNA positive people. They formed an open, dynamic population and could contribute to person time through multiple time periods. And so you can see here on the graph that people started contributing to person time when they receive an HCV RNA positive test. And then they would contribute until they either received an HCV RNA negative test, initiated treatment, were lost to follow-up, decided to withdraw from the study, died, or were administratively censored. So our Montreal sample included 320 participants. The median age was 44 years old. 81% of our participants were males. 36% of them were men who had previously had sex with men. 3% of our participants self-identified as Indigenous, and 90% of them had an annual income that was below the poverty line in Quebec. 80% of our participants had also previously been incarcerated in their lives. So you can see here on the left that HCV treatment rates were really low before 2014, around 5 per 100 person years. And they increased to 25 per 100 person years in the second generation DAA era. Same thing, for treatment effectiveness. It was around 50% before 2014 and increased to above 90% afterwards. Here you can see that needle and syringe sharing decreased twofold over the time period, from 16 to 8%. But you can also see that the use of needle and syringe programs slightly decreased. So these two results are kind of contradictory. And we think that because NSP has been available for 30 years now in Montreal, and syringes and needles are distributed at a lot of settings, including in pharmacies. We think that it's possible that participants underreported access to these programs in the recent years. So we think that needle and syringe sharing is a better indicator of access to new injection equipment among this population. We can also see here that supervised injection sites were rarely used because they were recently introduced. The consumption of the injection, of opioids has increased over time, and the percentage of visits at which OAT use was reported was really low. We're not sure yet how to explain this peak in 2011 to 2013, but in the last time period, only OAT was only reported at 6% of visits, and we know that the target for coverage of OAT among opioid-dependent users in Canada for 2030 is 40%. So in our study, we're still really far from this target, sadly. Of course, our study has limitations. HCV treatment uptake may be lower among the general co-infected PWID population because our study represents people who are already engaged in care. Patient-reported behaviors may be prone to social desirability bias or recall bias. And finally, some of the indicators that we presented were mathematically related. So in conclusion, recent increases in HCV treatment and reduction in syringe and needle sharing could reduce HCV burden among HIV-positive people who inject drugs. But harm reduction scale-up is probably needed to prevent HCV primary and reinfections among these populations. And we think that our results can inform our efforts to micro-eliminate hepatitis C among priority populations in Montreal in the framework of the Montréal Sans HC initiative. I would like to thank the conference organizers and all of you for watching this video, the Canadian co-infection cohort participants, co-investigators, and research team, as well as all of our funders, without whom this wouldn't have been possible. Thank you all.